Hello everyone, my name is Cristian Rotaru. I am a maxillofacial surgeon and I came from Bucharest, Romania, where I also have my private practice. Today I'm gonna talk to you about one particular procedure for horizontal bone augmentation. We are going to talk and see the surgical steps required to perform it. Before we go on to the case presentation, I would like to thank Dr. Salama and Dental XP for giving me the opportunity to share this case with you. It is a case where we perform the so-called Curie technique for horizontal bone augmentation in an atrophic third quadrant. I made a short video of this procedure and I will talk you through this video. This is the situation at intake, where we can see clinically the alveolar ridge shape that follows the bone resorption and also the CBCT slices in which we can better assess the bone loss. We start by making a crestal incision using a number 12D or 12B blade in some markets. We begin at the posterior aspect and slowly we advance towards the anterior teeth. We then use the same blade to do a circumferential cut around the bicuspid on the lingual, distal and mesial aspect. We will then change the blade to a 15C and we will do the anterior releasing incision. The elevation of the flap will then begin using a periostal elevator and the full thickness flap is raised all the way to the posterior aspect of the surgical field. We must expose the bone widely to have a good access to the area to be augmented and also to the area from where we will harvest the autogenous bone. This technique cannot be done easily if an incorrect exposure will be carried out. The first step that we do is to mobilize the lingual flap using a wide and blunt gentle instrument. In this case, we used a blunt periostal elevator. So this is done by gently blunt dissect the mucosa of the fibers of the mylohyoid muscle. You have to take special care in this step not to harm the lingual nerve or the lingual artery, so be very careful in this step. You can see here the lingual flap mobilization. I then like to do the releasing and mobilization of the buccal flap using the scissor, in this case a Lagrange scissor. I start on the anterior aspect of the flap by gently inserting the tip of the needle between the two layers, represented by the periosteum and the overlying mucosa. After carefully dissecting the two layers, I then cut the periosteum as high as I can, leaving a wide band of detached periosteum that I can then suture over the grafted side if I need to, in a periostal pocket flap manner. But I only do this in cases where I use titanium meshes or PTFE. I generally don't use it in cases with autogenous bone. If you will cut only the periosteum and not any muscle fibers, then the bleeding will be at a minimum all the time. Be careful of the mental nerve at this stage and always know where you are with your scissor. You can see here the mobilization of the buccal flap. Then you can start to harvest the bone from the linea obliqua externa. I use here the Lindemann burr. I know others are using the piezo or the microsaw. It is a matter of personal choice, I think. I find it to be more easy and quick for me without damaging the tissues, and I always stay in the cortical part of the bone. After I make the first osteotomies for guidance, I then deepen these initial osteotomies to the desired height of the harvest bone. If I need a bone plate of 7 millimeters in height, then I deepen these initial osteotomies to 7 millimeter mark on the drill. I will then proceed making the vertical cuts, the mesial and then the distal one. I don't do the apical cut anymore as I find it to be not necessary. If you make sure that you have cut in the same plane in the apical aspect, you will not need them. The plate will fracture at the base of your prepared plate. I am now connecting the first deep osteotomies in a horizontal type of cut. When you will try to fracture the plate, I recommend you use two long osteotomes or one long osteotome and a wide periosteal elevator, because if you use a longer osteotome, the moment of force applied to the bone is higher, using little force or effort from you. So, if you use the same force in trying to break the plate, the moment of force is higher if the distance is higher. So in this case, if you use a longer osteotome. Using a bone scraper, you can then harvest some autogenous bone chips that will later fill the gap between the plate and the host bone. Then you can start drilling for the screws you will use to stabilize the bone plate. In this case, I will use titanium screws of 1.5 by 10 from Medicon Germany. The bone plate must be as thin as you can prepare it, as this plate will only act as a space maintenance, an autogenous space maintenance. You don't need it to be thicker, as it will only reduce the vital bone you obtain in between the plate and the host bone. The drilled hole in the plate must not be wider than corresponding drill you use for this, so you don't need the lag effect you must obtain in the classical bone block augmentation. The screws must fit tightly on the drilled holes prepared on the plate. By keeping the plate at a distance from the host bone using whatever instrument you find suitable for this, in this case I use the Rochester pan forceps, you then begin to screw the first point of stabilization and then the second one. But always be careful that the bone plate stays at a distance from the host bone. You can see here the bone plate in place and also the mental nerve and foramen, which is located anterior and inferior to the operating field. You then use the harvested autogenous bone chips to fill in the gap between the host bone and the harvested plate. This must be done very carefully and meticulously to fill all the spaces between the two. For this job, I use a papilla periosteal elevator or a Lucas curette. I think you don't need any fancy instrument for this, but try to use the instrument that you find suitable for this. The great thing about this technique is that you don't need any collagen membrane to cover the augmented area. If you are only using autogenous bone plate and autogenous bone chips, then you don't have to cover with a barrier. You already have the vital bone cells there that will start working immediately for you. The osteogenic potential comes from the surviving osteoblasts. The osteoinductive potential comes from the osteoclastic activity that releases high levels of BMPs that will further induce the differentiation of mesenchymal type cells into new osteoblasts. And so, you have to let the blood supply come to this area from the flap above and also vice versa. The flap will receive blood supply from the new bone that will form beneath, and this will reduce the possibility of complication like flap dehiscence over the healing period. We will then begin to suture. I use here a 6-0 polypropylene suture with a taper needle, not a reverse cut needle. I find this to be more gentle with the soft tissue than the reverse cut, and I also like the half circle needle, not the 3/8 of a circle needle. I always start suturing first the distal papilla of the anterior teeth using a vertical mattress. The first suture is at normal speed recorded. The next sutures will be at x2 speed, so it will be twice as fast. I then continue to suture so the vertical releasing incision with a single suture for the crestal part. I then use a matrix suture and then another single suture. The success rate of this procedure, I find it to be high if you can carefully take the required surgical steps, if you follow basic surgical rules. The quality of the bone obtained at re-entry is far superior to other techniques. I usually re-enter at 4 to 5 months to place the implants, and I will wait another 2 to 3 months for osteointegration. You can see that now I began suturing the crestal incision, and we always do first the matrix sutures for complete flap immobilization. When doing the matrix sutures, You have to always take even bites from both flaps, around 2 to 3 millimeters from the incision, in order to obtain eversing margins of the flap and make a broad band of bleeding tissues come in contact. The suture is an important part of the surgery, and I always take my time in doing it. No need to rush things at the end, because you will not suture correctly. Your whole surgery might end up bad. So try to resist the urge to finish already. So this is my first case presentation on Dental XP. I hope you liked it. Um, and again, I have to thank Dr. Salama and Dental XP for invitation. Thank you.